Hello, welcome to my YouTube channel. This is Dr. Ayesha Butt, and today we have a very important personality educating us about refractive surgeries like LASIK and PRK, cataract surgeries, and cornea. I think we share the similar approach when it comes to patient-centered care. We both believe that patients' choices and their expectations are important. We not only need to communicate that to begin with, but we also try to meet those expectations as much as we can. So let's welcome Dr. Krishna Sura. Hello, Dr. Sura. I'm so excited to have you on board with us. I can't believe that, we'll be talking about a lot of fun stuff. Welcome to our YouTube channel.
Thank you for inviting me. I love talking about this, and I feel like I spend evenings talking to all these nuances of how to take care of patients best with colleagues, and it's fun to be finally on YouTube and be able to talk about it with our audience.
That's great. That's great. Would you tell us a little bit about yourself? What brought you
Sure.
in, ophthalmology and deciding to become an eye surgeon? What was your personal experience, and what brought you to a place where you are in now?
I went to medical school because I come from a family of physicians, and I honestly, like when you're young, when you're that age, when you're 18 and you're deciding where to go to college, and you're in college, I think you're kind of young to decide what you want to do with your life.
Right.
But I went to medical school because that's what I was exposed to. And I started medical school and I was a little bit unsure. But I really sat down and I did some soul searching. I thought about what I really enjoyed. I knew I enjoyed people. So I didn't want to be a radiologist, for example, right? I would be in a dark room.
Right.
I knew I enjoyed technology.
Okay.
So again, I was like, radiology has a lot of toys. And at the time, you don't really realize what this means. And in hindsight, I just had no clue, right? But I thought working with my hands would be fun. So I went into ophthalmology for all these reasons, because it was a great combination of those three things. But when I actually ended up being an ophthalmology resident, I realized I had it completely wrong. The reason why ophthalmology is so great is because we get to impact people's lives, and it's a short surgery. Patients are just so happy. And I can't tell you how many times a week or even a day patients tell us that we've changed their lives. Yes. And we have that ability, and it gives you this now that I'm approaching 40, you think about how what we want in our life is we want a sense of purpose. We want a sense of meaning. And I can't tell you how great of a career this has been, and I'm sure you can relate to
Absolutely.
that feeling.
There's a huge sense of accomplishment. I mean, you come home, there are days and you're like, okay, this is going to be a tough day, and your patient walks in and it's like, you have no idea. I can see. And then thank you for convincing me to do this. Yeah. Like, I'm talking about a lot of surgical patients where they had pre-op anxiety, or they're patients who would come in year after year and they're like, I'm not ready yet. I have so many things going on. But they're attorneys, they're doctors, they're engineers, they need their vision. Yeah. And at the end of the day, they just needed someone to tell them that it would be fine. Let's go ahead and do it. Did you have any experience with eye surgeries in your life, and how did you feel about it?
My mom was very nearsighted.
Okay.
She was over a -9.
Wow.
And apparently, I only heard the story like in the last few years, like after I was a practicing ophthalmologist. My dad told me that when she was really young, she hadn't told anybody that she needed glasses. And she was struggling in school when she was really young. And then apparently she's like the happiest person after she got glasses when she was young. Okay. And I mean, it was life-changing, right? And then, later in life, she ended up having LASIK. And LASIK was an amazing procedure for her because she all of a sudden didn't need glasses. When I was young, she'd use hard contact lenses. Yes. And she moved to LASIK, and she was so happy. And to be really frank, and we could talk about this separately if you want on another day, but LASIK was not the best option for her, even though she was so happy from it, just because her anatomy might have been better suited for another procedure. And I can tell you why I kind of developed expertise in all these procedures, partly because of that.
Are you pointing toward ICL?
I think ICL would have been a great option.
We can talk about it. I love it. I love it. I actually have a lot of patients that were waiting, and until the EVA lens came out. Yeah. I was just so excited. Yeah. So we'll definitely want to be talking about that.
Well, so we'll get into that. And then, later in life, she had cataract surgery, and she was so happy. So, she had cataract surgery after I had already become an ophthalmologist, which is a different story. But she saw so much happiness, and, I ended up needing glasses when I was young. And when I didn't have the glasses, it kind of defined who I was, my personality. Yeah. And I was always a nerdy kid, and I still am, but without the glasses.
I still am.
And then my dad told me, you might want to start wearing contacts, and I did,
Right.
and it kind of changed things for me. I was always nerdy, really scrawny, and I worked out a little bit more because of it. And then, I ended up having surgery myself about 6 years ago now.
Nice.
And, I went into it because, my partner, the person I was working with at the time, said, you should get the surgery. And I said, hold up, let me think about it. I'd been doing the surgery a lot, but it's different when it's your own eyes.
Right.
And to be really honest, I briefly had a moment of anxiety about it. I really depend on my vision, like a lot of people you described. Right. And I had the surgery, and I'm so happy because it gave me one less excuse to go to the gym. I all of a sudden was in the shower, and I didn't have to guess which one was the soap or the shampoo. And it's all these small things you take for granted, and I'm so happy that I had surgery. And so that's my personal experience with having had eye surgery in my life.
Tell me a little bit about patients who walk in with this LASIK and PRK in mind. How do you decide what is the best option for them? And frankly, how do you approach that, and how do you educate them that I feel that this is the best, and get them at the same level where you are at?
So that's a really good question, right? And so I try to think about it from like a zoom out on Google view, right? When a patient comes in my office and they say that they want LASIK, what they're really telling me is that they want to get out of glasses, right?
Right.
But really, there's so many options now, right? We have 6 different procedures to treat patients' vision.
That's awesome.
And you have patients who are 70 years old, and as an eye doctor, a 70-year-old patient has cataracts. They don't need LASIK is not the right solution for them.
Exactly. So
but we have a number of different options. So part of my job as a surgeon is to develop expertise in each of these procedures and find the best procedure for the patient.
To get to that outcome.
And so, I start the conversation, and if they came in asking for LASIK, and I think LASIK is the best procedure for them, great, let's do LASIK.
Sure.
But if I think there's another procedure, so, going back to my mom, I try not to do LASIK above a -8. Yeah. I reserve LASIK for either -8 or lower. And same thing with PRK. I actually try not to go above a -6 unless there's another reason that they should. But I think ICL is such a great option where we implant a contact lens. It's this new technology where we implant a contact lens behind the iris. Patients can't see it, they can't feel it, they have immediately better vision.
That's great.
And we can remove it.
How high of a prescription can you treat with ICL?
So ICL in this country starts at -3, and it goes up to -16, and we can treat up to 4 diopters of astigmatism. Okay. But with that said, my highest for this year, she's a -21. Okay. And so for her, I treated her with the highest prescription that we can have for ICL, which is -16.
Did you do any other procedure? Like, are you able to do an ICL along with LASIK?
So for her, I'm planning on doing LASIK for her on top of the ICL. Perfect. And I'll tell you, it's so crazy to me that she cried after the procedure. Her family cried right after the procedure. And I haven't even fully corrected the vision yet. Yeah. These are life-changing procedures, because when you're at that level of prescription, it's not an inconvenience of glasses of being a -2, right?
Absolutely, yes.
It's patients who have debilitating vision. They're disabled without their glasses or contacts. And
I had a 45-year-old female patient, a mom of 3 kids. She's basically her job is to make sure that her kids are taken care of, right? And she's safe to drive. -20 something. Yeah. So I just recommended a clear lens exchange for her, and I'm like, just be done with it, because she wasn't a candidate for LASIK, and she was in scleral lenses for a long time. Like we did about 5 or 6 years, and then eventually she just couldn't. Yeah. So. How do you make sure that you approach the patient and focus on, so, we talked about a 70-year-old, their best option would be a clear lens exchange. A patient who's really high prescription, then they want to get LASIK done and may or may not be a legitimate candidate for cataract surgery. What about an 18-year-old, very, very young, healthy, and their prescription is stable, they're now ready? What is the minimum age you would do LASIK or PRK for?
18.
Okay.
And so it's FDA approved in this country for 18. The one comment I'll make to an 18-year-old is that, look, you're at a slightly higher risk potentially your vision changing. Right. And if you can accept that, we can treat it now.
Right.
And if we need to do enhancement later, we can, no big deal.
Right.
And so I'm okay with treating a patient 18
Sure.
as long as they understand that, right?
Right.
It's all about expectation management.
Absolutely. What kind of tests or discussion is important to make sure that they don't end up or they don't have any disease? Like what kind of makes sure that they are good candidates?
So that's a really good question, right? So I really believe that it's really important to do a really thorough exam with the eye, both clinically and with the testing that we have. And so maybe it seems like a little bit onerous and somebody comes and visits us, they're like, why are you doing this many tests,
Yes.
right?
Yes.
So for example, for a refractive patient, right, a patient who comes in for LASIK, right, meaning they want to get out of glasses, right. And let's say they're 30 years old, we do one topography. It's an OPD3, which it's a placido topographer, and it measures their optics of their eye. Right. We do a Penacam. Depending on their prescription, we do an IOL master. Okay. So at this point, we've done 3 topographers. We've done 1 biometer. We've measured the optics of their eye. We get a sense of the anatomy of the eye because, for ICLs, you have to have a certain amount of anterior chamber depth to be able to implant it.
Yeah, we need space for the lens to go in,
right.
yes. Yeah.
And then we do something called a vario scan, which is it's a 4th topographer. So basically it helps take that information to the LASIK laser in case we decide to do it. And it actually gives us a lot of information on the higher order aberrations of somebody's natural cornea. So if they have a lot of coma, right. we may want to think about doing a topo-guided treatment as right. opposed to just a standard LASIK treatment. Right. And then we would do an Optos because I think we can kind of get wide out to the periphery, but we still do like a peripheral exam of the retina. Mm-hmm. And then we do an OCT. We do something called the epithelial thickness map. So certain patients may be predisposed to having keratoconus, and believe it or not, all these topographers may miss that. So the thickness of the epithelium can actually tell you whether the patient has keratoconus, which gives me a reason not to do that procedure. Right. And then finally doing an OCT. And if there's any question about nerve issues.
Like you're making every effort to make sure that there's less chance of developing a keratoconus. You won't believe it. I've seen so many patients who went ahead and they got a cheaper or more affordable LASIK done out of this country, right? Yeah. And they developed keratoconus, or they had keratoconus and they should not have done LASIK or PRK. So, is it because we're using different technologies for screening these patients at different kind of parts of the world? And, also the second part of the question is, why is it not safe to just go with the cheapest possible option?
So, refractive surgery has been around since the 40s. Yes. And so it started in Japan, and it was the precursor to RK. And an RK, became popularized in the 70s and 80s. In this country, PRK was approved in 95, LASIK was approved in 97, ICLs were invented in 1991. Mm-hmm. I mean, there are just so many technologies. Right. So, but it's interesting, until about 25 years ago, we really didn't have like a great tomographer, and it wasn't standard of care. Right. So we really weren't doing keratoconus screening. Okay. So, the incidence of keratoconus is about 1 in 10,000. It's quite low, okay. But nonetheless, we don't want to induce it. Right. So part of it, I think, is being thorough. And then sometimes when we have the data points, I think we should really think about it critically, right? I think that we shouldn't pick a patient who's higher risk. Okay. If they're too high risk for LASIK, we should pick ICL. Right. If they're too high risk for LASIK and they're too high risk for ICL, and we can't do a refractive lens exchange, or we don't have any other procedure for them, we should pick no procedure at all. Right. I think it's important for us to rule out patients because, LASIK, we do somewhere between 600,000 to 800,000 procedures a year in this country alone. Yes. It's a lot. It's an elective procedure. It's been studied probably more than any other elective procedure. Right. But if we're going to do it on a patient, on a healthy eye, we should be very careful about how we're doing it. Right. And what I mean by that is we should be very careful about patient selection, picking the right procedure for the patient if it's appropriate. Right. And at the end of the day, part of my job is risk control, right? So I can do everything I can to really lower risk. For example, if a patient is a high myope, I send every one of those patients to a retina specialist to make sure that if they see any opportunity for treating lattice degeneration, they can. Right. And I feel like part of managing risk is to manage it before the surgery.
Absolutely.
And
Intervention.
so, just to answer, like, it's a big question.
Yeah, that's all.
I think that ultimately, if they have an issue, being there for them is important too.
Right.
And so when we talk about the cheapest LASIK, the problem is that you want the surgeon involved during the surgery, even if it all goes well. And if there's a small chance that there's an issue, and for LASIK, just so you know, the risk of having an issue is about 1 in 1,000. But almost every issue can be managed.
Yeah.
And I always tell every patient this, the risk of your vision being worse is about 1 in 10,000.
Right.
But that's if you go to an experienced surgeon who's ethical
Yes.
and is going to be there for the patient at the end if they need it.
Right.
And just so you know,
And
there's
technology matters. Like,
and technology matters.
You don't want to be. It's like you have all these resources. You have all this technology. Why would you not use them?
Correct.
It's your eyes. At the end of the day, you don't want to be just. Yes, there is a cost associated with it, but at the end of the day, it's your vision and technology. If it's available, it's definitely worth it. I want to go back to 2 questions. You mentioned the involvement of retina specialists prior to the surgery.
Correct.
Let's talk about laser-assisted cataract surgery versus the regular cataract surgery, and why do you think would it be important for someone who's high myop or anyone who has retina conditions or retina involvement?
I don't necessarily feel that laser-assisted cataract surgery helps with patients who are high myopes necessarily.
Okay.
I think that it adds precision to the surgery. It adds precision in how we treat their astigmatism. We treat their
Would you
refractive
mind
error.
describing it a little bit for
Yeah,
our
yeah.
audience and just kind of like break it up into what is the difference between a normal cataract surgery and a laser-assisted cataract
So
surgery?
if you think about surgery, you can break it up into different steps, right? And so depending on who you ask, you can call it 3 steps or 10 steps, depending on how granular you get.
Right.
But let's call it, let's say 10 steps.
Okay.
Laser-assisted cataract surgery, what it does is that it does most of the most critical steps of the surgery. And so what it does is that it increases the precision, it increases the safety, and it allows us to give patients better outcomes, right? So I think that not every patient is a candidate for it, but if you're a candidate for it, like my own mom, she had laser-assisted cataract surgery, and I thought that, why wouldn't I take every advantage I could, right?
Right.
To give her the best vision.
What do you think? When my dad had cataract surgery in Canada, I'll be honest, he was given a sheet of paper with a bunch of options, and it was toric, spherical, laser-assisted. He had no idea. He's like, Ayesha, I'm sending you the piece of paper the doctor gave me. Can you please explain me what I should get? And I'm like, so the doctor did not explain. I don't think a patient should be picking and checking. This is important. How do you guys talk about that in your patients in your office? And how do you come up with a final IOL or an implant that a patient would be very happy with?
Have you ever heard that advice? You can only, when you have a conversation with somebody, or if you give a lecture, there's only 3 pieces of information you can hope that a person can walk away with.
Right.
3 pieces of information, right? And so I've really thought about that. And I think overloading the patient with information is not valuable.
Absolutely not a good
So
idea.
I'll take my mom, for example. I keep using her as an example. But she had surgery with someone who I think is an outstanding surgeon. He's world famous. He's at a local academic center. I have tremendous respect for him. But kind of like what you described, he gave her a piece of paper, and she had a bunch of options. And my mom is fortunate, I suppose. Like I'm fortunate to have her as my mom, but I was there to kind of help
or my dad,
help navigate
here,
that, right?
yes.
And my aunt recently, she lives in North Carolina. She had a similar situation where she was at Duke, right? And Duke, obviously, she went to. We sent her to an excellent surgeon, and it made sense for her to go to the follow-ups there. And same situation. And I think that's just too much for patients. And if you're a patient, what do you care about? Do you care about the features of what you're going to get? Or do you care about the function you're going to get out of it, right? And ultimately what patients care about is like, what am I really going to get out of it? Like there's a patient actually that we're taking care of together right now. And he's in his church choir. And you know what he told me he wants? Nobody thinks of their vision until they're presbyopic about distance or near vision. It's such a crazy concept. But we're introducing so many things to the patient at one time. All he wanted to be able to do is look at the conductor and look at his notes. And he's telling us what he wants in his life. And so that's what we really need to pay attention to. And to be honest, like one of the great things, and we'll get to this later, I'm sure, about collaborative care is that you know the patient. You can help guide me to help guide the patient.
Yeah, it's amazing. It comes from your personal experience. I had an
Yeah.
ACL injury and I went to my knee surgeon. Of course, that was my third opinion. You want to be
Yeah.
comfortable. So I'm like, yeah, in addition to being handsome, I want to know what he can
Yeah.
do for me.
Yeah.
So I walk in and, after reading and just talking a little bit, he's like, Ayesha, what do you want? What do you want to achieve after the surgery? And I'm crying, of course. I had the ski injury, and
Yeah.
I said, I need to be able to sit down on the floor, bend my knee, and I want to be able to do that. A lot of patients, this is after a lot of homework and YouTube videos and Dr. Google searches, right? And I said, you're amazing. You asked me what I want, what I expect. You're the first surgeon out of 3 who asked me, Ayesha, what do you expect after you recover from the surgery? And I told him I want to be able to sit down, bend my knee, and be able to pray. And he made that happen, but he told me how we're going to get there. He didn't give me a sheet of paper and ask me to check mark things that I need in my knee in order to get that knee to be bent. I don't know my knee anatomy. I don't know what I need to. But that's how I feel that my patients come to us for. You sit down one-on-one having a discussion about, all right, let's dream that you are in this perfect world after your surgery. What do you want to be able to see when you wake up? Are you a professional driver? Do you want to be able to do your makeup without your glasses? I have so many patients who are nearsighted, and the last thing they want to do is lose their nearsightedness, because now they can't see their face or their hands, and they can't do their nails. So it's amazing that we tend to, a lot of surgeons in the past, and things have gotten so much better thanks to you guys. A lot of younger surgeons understand that we need to do what's best for the patient. Let's focus on the patient. Let's make them the center of attention and make everything possible for that to happen. And that's where the OD-MD relationship comes in.
Totally. And I'm gonna, by the way, one thing I got to say is I'm glad that I'm here this morning because I learned one thing from you already. It's a really high-level question, right?
Yes.
What do you expect after you recover from the surgery? And I'm going to actually take that from you and adopt that in my own practice.
Please do.
Because I think it's such a great question. Because ultimately, it's not about the technology. It's about what the patient, how they want to live with their vision. And there's nothing you use more than your vision in this world, right? And I think that we have to make it really simple for patients, for them to choose. And in my practice, we get a sense of that. We spend time with them. And just to go on a quick tangent here, I'll tell you that one of the challenges in modern medicine is that it's become all about volume.
Yes.
And our practices, we're independent practices. We're about being the alternative to the volume practices. And the challenge with the volume practice is that, I heard somebody else recently say that they walked in the room and the surgeon took a look at them and they said, you have cataracts, when do you want to schedule? And then they send them to...
Or they walk out and they have a technician there kind of talking about, no, I want to be the doctor who communicates with my patient. And yes, unfortunately, I don't believe in drive-through experience. I believe in patient communication, patient-centered approach. And you can't do that. If you're my surgeon, you better be available to talk to me.
And there's a sacred covenant in that conversation that we have because I'm looking you in the eye.
Yes.
Some other person can't have that conversation because I know how to best deliver that, and the patient knows best what they want from their surgery. So only the patient and I can have that conversation. And so what I'll say is, like, to make it simple, we talk about this checklist, and I wish we had one to kind of show our viewers, but it's crazy, right? You agree? And I just tell patients, like, do you want to be out of glasses for distance, near, or both?
Yes.
And it's a really simple question.
That's it.
It shouldn't be more complicated than that. And if a patient wants to go through 2 pages of questions, I'm happy to.
Sure.
We'll go through every nuance. We'll go through every rabbit hole. But I don't think everybody's equipped to have that conversation. People want it to be simple.
Right.
And I think the simpler we can make it for patients, the simpler they can understand. And I'll talk to them about the nuances of each of those options. But I think it's important to make it as simple as possible and to kind of tailor it to their lifestyle, to their needs, to their wants.
Absolutely. Patient education. I would rather be the source of their information instead of them, searching something on Google and finding out that they can have retinal detachment.
Correct.
That's the scary part, that, there's so much out there that it may not be even relevant to them.
Yeah.
So that's where we come in as their doctors. So let's talk about a little bit of, presentation and so pre and post-op. So what do you expect in a patient who comes in for cataract consultation? And what would be a perfect referral or patient be? I feel that when I'm sending my patients, I'm wanting to make sure that, you know, their dry eye is taken care of and everything else is just, their eye is just as perfect, healthy as it can be, other than the cataract. Do you sometimes get patients where you have to start from scratch and kind of maybe pre-treat them? Yeah.
So I think it helps for patients to have an understanding of their eyes before they come in the door. It's not infrequent that I have a patient who comes in and for the first time they're being told that they have an epiretinal membrane. They're being told that they have glaucoma. And sometimes I have to delay the surgery conversation a couple times because I think that I need them to wrap their heads around the glaucoma because, as you know, like cataract surgery is an amazing surgery. Patients are often happy with it. But, you know, cataracts can eventually cause them to lose vision. But, you know, most cataracts that we do in this country, it improves their quality of vision a lot, but it's not going to blind them. Glaucoma will blind them permanently. And there's nothing we can do. So I feel like we have to take a step back sometimes. So if they have an understanding of their eyes and their eye health, that's very valuable. You know, optimizing their surface is valuable. Understanding who they are as a person. Are they a really nitpicky person? And they won't like some of the trade-offs that come with the distance and near option, right? Treating presbyopia. Are they the wrong person for that? You know, it helps. And by the way, I've had like patients that are engineers that have been really successful at multifocal lenses. I just think it takes like really paying attention to anatomy and all that testing, I think helps. And understanding their personality. But if I have an understanding and the patient has an understanding of these things before we walk in a room and we meet each other, it's really helpful because when I go in the room and I talk to them, as I mentioned, I try to keep things simple, but I still got to talk to them about what to expect with surgery. I still got to talk to them about, you know, the risk profile of the surgery. And I have to walk them through like helping select their vision that they're going to have for the rest of their lives. But the more they know about that, that's valuable. And so I really thank you for doing that for patients that you send me.
No, it's important. Like I had a patient who had 3 retinal detachments and now we're sending him out for cataract surgery. You can't tell this patient that your vision would be perfect after surgery because we have something else to deal with here. And it's amazing how we fail to sometimes communicate that with patients and then they end up having wrong expectations or something that's not achievable. You know, I always tell them there is a film at the back of your camera. You know, the film is a little bit thick right now. You know, we can replace the lens all we want, but if that image is not crisp, it's not falling on the film. I try my best to communicate with them at their level, so I try not to use a lot of medical terminology. In my office, so we have an eyeball that we use, but I always use camera in my hands and kind of show them, look, it's peeling off, and we need to, you know, co-manage with so many different professionals, and that's in your best interest, even if it means delaying the surgery for a month or 2. And they understand that. They appreciate that, actually, that, you know, I'm so glad that I didn't rush into it, you know. I'm actually treating a dry eye patient who has a basal cell carcinoma, and we're co-managing with 3 different doctors at the same time because we want to make sure that everything is done correctly. But that's the same thing with you. Like, you would want to involve all the doctors in there and then, you know, be on the same page. Let's talk about those perfectionists. You know, we live in Houston. My husband is in oil and gas. He works for Shell. And I see a lot of, you know, engineers. They are so particular about their vision. Is there any lens for that? Like, let's say, you know, like my husband, he never needed any glasses. And, you know, unfortunately, he doesn't understand, you know, what kind of work I do. So let's talk about the light adjustable lens. And, you know, when would you recommend that lens to patients?
So let me address something you said first, and we'll go there. One thing we have to understand in this life is that perfection is not real, right? There's no such thing. And so if somebody says, you know, they want everything to be perfect, I just tell them I don't think that's possible. And if they can accept that, great. But, you know, anybody who would tell them that everything's going to be perfect after surgery, I think that's, they're setting unreasonable expectations.
That's true.
And I don't think they're doing themselves or the patient a service. Right? So I think that to answer your question,
that you said that.
Yeah, so I think it's really important to kind of acknowledge, right? And I tell patients this, and some patients tell me, well, what kind of outcome can I expect? And look, I have a pretty good sense, you know, I've done somewhere between 5,000 and 6,000 cataract surgeries. I have a pretty good sense of where the patient's going to land. And I know my data, right? I don't tell the patients, but like, you know, over half my patients end up at 2015. And so, which is great.
That's better than perfect.
That's better than perfect, right?
In our terminology.
In our terminology, right? But I'm very careful about telling patients this. And if a patient asks me, do you think I'll be 20/20 after surgery? I'll never commit to a number. Because I just think that there's a lot of things that you can't predict. And patients and have this high bar, and there's something called the expectation quotient.
Right.
Disney talks about this, by the way.
Yes.
If you tell people that a ride is gonna be 45 minutes long to get to, like the wait is 45 minutes long, and you're at 50 minutes, people are antsy, they're upset.
Right.
If you're at 40 minutes, people are really happy.
Right.
So it's all about lowering the expectation to a reasonable amount, right? I don't want to
You always want to over-deliver.
I always want to, correct.
Yes, and that's true, that if you just tell them everything is going to be perfect, then they're expecting that. And, I'm not saying lower your expectations, but just, prepare them accordingly.
Somebody taught me this. Post-op happiness is equal to post-op reality minus expectation.
Right.
Right? Like you
Absolutely.
And I think that's a really important thing. And it's one of the hardest things we have to do.
Yeah.
Because we really have to manage expectations. And look, I really believe that I have a practice where we have every technology that you can imagine in modern ophthalmology. And I want to deliver the best.
Right.
But with that said, I think patients should expect a lot.
Yeah, they should.
But with that said, I think that they have to have reasonable expectations going into it.
I love it. I get text message, Ayesha, your surgery went well,
Yeah.
but there was small corneal abrasion. So I walk into my room prepared for that.
Yeah.
I'm taking my slit lamp photos. I'm showing that to my patient. I'm communicating with them.
Yeah.
Because obviously this patient is not seeing very well with that abrasion.
Yeah.
So it's just having that communication between professionals and being prepared for the patient that they're going to be anxious. They were not expecting that, but we already prepared them that things like that can happen.
And to your point, and the other important concept I think is delta.
Yeah.
And so I had a patient who I saw just recently, and he thought he had cataracts. And his vision, one eye was 20/20 and the other one's 20/40, right? And his cataract was like 1 to 2 plus NS, right? Okay. So pretty mild cataract, emmetrope. But I don't see what I'm going to improve for him. His 20/40 eye, by the way, had some retinal changes in the photoreceptor layer. I'm not going to improve anything. So if I don't think I can improve the patient or make them better, I don't think it's worth doing surgery. I think a lot of people are quick to do surgery, but we have to give patients something meaningful. We have to make them better. So think about the delta also when you're talking about expectations with patients.
Absolutely, yes. Yeah,
and so anyway, to go back to your original question about lenses,
yes.
Here's my overall statement. I don't think there's a perfect technology for every patient.
Okay.
But to answer your question about light adjustable lenses, I think it's an amazing technology because the power of light adjustable lenses is that, one, it's a silicone lens. It has better optics. It has the similar refractive index to the natural eye. Nice. So we have the leastest photopsias of any lens. Okay. And the other beautiful thing about light adjustable lenses is that we can adjust the prescription after surgery. And there's something powerful in you choosing versus me choosing for you, right?
That's great.
And I think patients love that. Yeah. And, even... I think it's amazing technology.
You have a patient who's a shooter, and they want their vision to be just, so they can now choose their prescription after the actual procedure, which has never been done before, right? So this is the first. That's beautiful.
It's beautiful.
That's awesome. All right.
And I'll have some patients, like I had a patient earlier this year, her mom wanted cataract surgery, and they come in, and she knows the options, right? And she's talked to her mom about the options. And this is the first thing she says to me. My mom doesn't want a multifocal lens. I don't think she would tolerate it. I said, okay. And the second thing she said to me was, but she wants distance and near vision.
Oh, that's...
And then I said, okay. And then she said that, and she doesn't want a trade-off.
Oh, great.
And as you know, there's always some trade-off. Right. It's all about having the least trade-off and finding one that the patient can tolerate. Light adjustable lenses is a perfect technology for her because she can choose afterwards. And she may say at the end, look, I want both eyes set for distance and I want to wear readers. Right. Or I think almost every patient, as you know, will tolerate 0.75 in isometropia. And the beauty of light adjustable lenses, the way that the defocus curves work, is that they haven't added about a half diopter. So even if you end up giving them only like 0.75 in isometropia, they actually have about 1.25 in isometropia. And a lot of patients end up like J1, J2, which is better than cell phone vision, better than restaurant menu vision. Right. Probably the few things that are missing are maybe looking at the small print on the medicine bottle, or looking or being able to sew. but they can do most things.
That's great.
Yeah.
That's like going back to my surgeon and saying, Ayesha, let me just do the surgery and then we
Yeah.
can adjust what you want later. That's really good.
Yeah.
That's amazing. Well, thank you so much for educating us so much about different options and
Yeah.
just, overall, what's important is that there's so many options and it's a safe procedure, like you said, both LASIK, PRK. Is there anything that you would like to share with our audience?
I think we're living in an incredible time, right? We're living in an incredible time. We have more options than ever. I don't know if you know this, but there's 9 companies that make monofocal lenses. There's multiple diffractive lens options now. There's another 3 that are going to get approved in the next couple of years. We have EDOF lenses. We have adjustable lenses. There's going to be more options for how we can adjust people's prescription after surgery. There's so much technology that we have available. And I think it's on us to figure out the nuances of all these technologies. And similarly, it's important for us to figure out what our patients want, what our patients' eyes are capable of, right? Understanding their anatomy and kind of matching all of them.
That's absolutely true. So I specialize in cornea and keratoconus. So a lot of my patients are just kind of like in that range where they're waiting for a corrective surgery or option. So what can you tell us about vision correction surgery in addition to cross-linking for those patients who have keratoconus?
So briefly, let's talk about cross-linking.
Yes.
So it's really unfortunate that cross-linking only became approved in this country less than 10 years ago.
I know. It was approved in Canada when I was a student 10 years ago.
Right. Crazy, right?
Crazy.
Actually, I saw a patient earlier this week. She was sent by a colleague from east of here, about a couple hours east of here. And she basically was told she had astigmatism. It kept getting worse. Nobody diagnosed keratoconus. And eventually, she had eye drops. The cornea failed. She has bilateral transplants. She's 39.
Wow.
So I think in modern times, there's no reason to not have cross-linking, because at least we can stabilize people's keratoconus
What is
and keep them.
cross-linking for our audience?
So cross-linking is a technology where basically we can use a special medicine and a special UV light in a certain pattern to strengthen the cornea. So keratoconus is a disease where your typical cornea is kind of like a dome shape. And in keratoconus, a lot of patients have progressive disease, where instead of being a sphere shape or a dome shape, it turns into a cone. And at some point the cornea fails and you can't see through that cornea. Cross-linking strengthens that cornea to keep it from becoming a cone and keep it from failing. So
we're essentially preventing it from getting worse, but we're not really treating. A lot of patients expect that we're sending them for cross-linking.
Correct.
I can see the same. My vision didn't change. Well, it's not supposed to change with cross-linking. It's supposed to just strengthen it and prevent it from progression. Sorry, you were saying.
So to talk about options, so one goal of keratoconus, if it's progressive, is to keep it from getting worse. So cross-linking is an amazing option. I'm glad we have it now. It's effective. I mean, it's unfortunate we didn't have it before.
Are you performing both epi-on, epi-off?
I'm performing epi-off and
Which
epi-on.
one? Like, how do you decide?
That's a really good question. I think it really depends on the patient, right? If I had excellent vision still and had progressive keratoconus, I think I'd want epi-on. If I had terrible keratoconus and my vision was pretty poor, I think the risk profile of epi-off is justified. So I think, again, we just have to find the right procedure for the right patient, for the right cornea, right? So one goal of cross-linking, of course, is to stabilize the cornea, keep it from getting worse. The second goal is most keratoconus patients have poor vision, as you know. And I will say this over and over again, and I say this to every single patient. The best solution for correcting their vision is clear lenses, hands down. But as you know, a lot of these patients are just tired of their hard contact lenses.
They can't wear glasses. They don't have any other options. So, it would be nice to know that they can actually get some vision correction.
And you know how it is. Like, you have a long day. You want to come home. You want to take your glasses off. You don't want to have to leave your contact lenses on. You don't want to feel like you're dependent on something.
Absolutely.
And so there's some new technologies for how we can treat that. So you might be familiar with, so I wish we had a picture of keratoconus, but basically it's an irregular cornea, right? There's a bulge in the bottom of the cornea. So for a long time, people were doing a procedure called intacs. Basically, they were making like a little tunnel, and they were using a piece of plastic to basically regularize the cornea, right? But what we've learned about intacs, and I know some people are still doing it out there, but I'm just not a fan of it. You're putting a piece of plastic in the cornea. We've learned
I have
that
quite a few patients with intacs, and it's not comfortable.
It's not comfortable. Some of them extrude. And we've learned that the cornea doesn't like foreign bodies in it.
Yeah, of course.
And we don't have to get into this, but there's another procedure called inlay. Same thing, right? Both those companies are not selling them anymore. I think one of the companies even closed.
Okay.
So I don't think putting a piece of plastic makes sense. The newer technologies that we've had to replace intacts, one of them is called CAIRS,
Okay.
C-A-I-R-S. And another competing technology, it's out of Cornea Gen in Seattle, is called CTAK, C-T-A-K.
Okay.
And both technologies are amazing. Basically, instead of putting a piece of plastic, we're putting donor tissue into that tunnel to regularize the cornea. So it can help with two things. One, it can make them potentially soft contact lens or regular glasses tolerant. Or some patients, as you know, you can't fit them in a scleral lens. So it can potentially make them scleral lens tolerant. So those are great technologies for that. So that's one very interesting set of technologies that are being developed.
I would love to learn more about it.
Yeah.
And of course, it's for our patients. I think there is just light at the end of the tunnel, right?
Yeah.
Like there's hope for them. And that's amazing. Is there anything that's
another
coming
technology
soon?
that I have a great interest in? And so there is this Greek ophthalmologist. His name is John Klanopoulos.
Okay.
He's in Greece, and he started something called the Athens Protocol.
Okay.
And he has over 10 years of data now. And it's really amazing. What he's shown is that you can combine topo-guided PRK, and I'll talk to you about what that is in a second, with cross-linking.
Okay.
So what that means is, like, it sounds crazy, right? Doing refractive surgery on a keratoconus. We just talked about how we don't want to do refractive surgery on a keratoconic eye, right? Or on an eye that
how many patients want to actually do that? They would do anything.
Well, those patients are the patients that have the worst vision, right?
Yes.
They want a solution. And so now we have a technology. It's called topo-guided PRK. And basically what topo-guided PRK does is that we map out the cornea with 10,000 different points. And our goal with topo-guided PRK, and this is a really important concept for our fellow eye doctors to listen to, our goal isn't to treat their prescription. Our goal is to basically regularize their cornea. We're trying to normalize it so that way they can tolerate a soft contact lens.
Okay.
They can tolerate regular glasses. And so what we do for this procedure is that we combine both cross-linking and topo-guided PRK. We do a small treatment. We do less than 50 microns. We want to make sure we have at least 400 microns to do this treatment.
Sure.
And patients do amazing. Like, I have a patient right now. I haven't started doing it yet,
So
full disclosure.
Okay, that's okay.
And I sent him to one of the country's experts. His name is Mark Lobanoff. He's in Minnesota.
Okay.
And he went, and we're like 3 months in. It's incredible. He went from uncorrected vision, or sorry, best corrected vision with soft contact lenses of, I want to say, like 2150. And he's about 2.5 months in. His best corrected vision with soft contact lenses, not sclerals, is 2030.
Wow. You know what? I'm sending this video to all of my keratoconus patients.
Yeah.
This is going to be amazing for them to know that something is in works. When can we expect you to be able to do that?
So that's a really good question. So right now, I'm working on setting up the technology.
Okay.
So basically, what we're going to do is that we're going to map out the corneas, and we're going to bring it to Texas. I have another colleague who's in the DFW area. We're both bringing it to Texas at the same time.
When you say Texas, Houston or Dallas?
Houston and DFW. So me in Houston, and he's going to, Dr. Mueller is going to offer it in DFW.
I can't wait.
And so what we're going to do basically is we're going to map out the cornea.
Okay.
And the company that makes this laser, the topo-guided treatment, we basically have a person within the company, and we have a small panel of people, including Mark Lobanoff up in Minnesota, and we plan out the treatment. Because I do the PRK treatment all the time for patients here for our regular corneas. And we plan out the treatment together, and we do the math, and then we do the same treatment that's offered in Greece, offered in Minnesota, and we're going to offer it here. And then we wait 6 months, and if a patient really even wants to get out of glasses at that point, what we can do is that we can offer them ICL technology, which is a treatment where we implant the contact lens, which leaves the cornea untouched, and potentially gets these patients out of glasses.
That's awesome.
So the person I sent up to Minnesota, it's amazing. He's a maestro at the opera, and he told me that it was an opera that he was very familiar with, and so he knew his notes, but he had a situation where his lens moved, and for the last 10 minutes or so, and he said that had he not memorized it, he would have been in huge trouble because the entire opera is like counting on him to conduct. And I don't know, I think that he's so happy he is actually about to do his right eye.
Oh, that's such a great story. That's amazing. Well, I'm definitely looking forward to learning a lot from you, Dr. Sura. This has
Yeah.
been amazing. You know, we can go on and on.
Yeah,
I
yeah,
think
yeah.
this is definitely helpful. We would love to bring you back, learn more from you,
Yeah.
and I also think that it's amazing to have like eye models or things like where you can actually educate patients. But sometimes patients just want to hear you.
They just want to hear it, right?
They want to come in and ask questions. Once again, thank you so much for coming in. You know, this was a short notice.
Yeah.
And I think that I learned so much, and I'm hoping that, you know, our audience learn a lot. And if you guys have any questions, we'll share Dr. Sura's information with you so you guys can ask one-on-one questions. Thank you
Perfect.
so much.
Thank you
again.
for having me. I really enjoyed this. This
Yeah,
is so
same
much
here.
fun.
Same here.
Yeah.
Thank you.